All right, so for our online students, we've decided to continue on with parameters and trade-offs just because of the scheduling conflicts a little bit later in the semester. And we'll hold procedures until next class. So let's continue on with our TR. All right, so I said as we were ending the lecture that as we increase our TR, we're going to increase our signal. And that is proportional. So you see here we have 4 sagittal branes. Which sagittal brane do you think has the highest TR?
A.
Okay. Which has the lowest?
D.
Good. So D is never actually a parameter we would ever really use. So D is actually a TR of about 140 milliseconds. What is our lowest TR we should have for a T1 pulse sequence? 20. TR. T1 for T1 pulse sequence. It's a range. 200 is at the very low end, but usually like 300 to 700. 300 to 700. T2 is 2,000 to 7,000. Remember that? So really, D would be an undiagnostic image. So we don't want to have a TR of less than 300 milliseconds for a spin echo pulse sequence. C, that is actually a TR of about 300. So, but you can see here our image is still pretty grainy, right? And then B is a TR 500, which is in with the range, and then A is at the high end of our TR. You can see here all these are T1 weighted images because our signal from fluid is dark. So our fluid has yet to recover, so we're still not getting any signal from fluid. We have very bright fat down here, and then our fat starts to get darker as we go because it's starting to get more and more T2 weighted as we increase our TR. So the trade-offs with TR, it's incorporated into our scan time equation. So as we increase our TR, yeah, our signal goes up, but guess what goes up also? Our scan time. So as we increase our TR, we increase our scan time. And here's our scan time equation for a 2D pulse sequence. TR times the number of phase encoding steps times next. All right, our next parameter is our TE, our echo time. And our TE controls the amount of transverse magnetization allowed to decay before the echo is collected. So I have an image here of our signal. So remember, right after we turn off that RF pulse, what happens? What's this also called, the acronym?
FID.
Your FID, good. And then we have a 180-degree refocusing pulse that happens around this time frame to regrow the signal. And then it regrows to peak amplitude, TE, and that's usually where we're going to be recording our signal. So this slope right here is associated with that T2 decay slope. And you can see here, if we have another 180-degree refocusing pulse, yeah, it regrows our signal, but it's not going to regrow as much because we're going to still get a general trend of decreasing signal as we go along. This is what we call a dual spin echo, where we get 2 echoes. The second echo is always going to be less than the first echo. There was less transverse magnetization to refocus on that second echo. So, as we think about it, if we have a longer TE, more transverse magnetization is allowed to decay, so we're going to have less signal when we're recording that signal. But if our TE is short, our or transverse magnetization, which is where our signal's at. Remember, transverse planes, we're collecting signal. We have a short TE. We haven't had much decay of that signal, so our signal's going to be higher. So this is an inverse relationship. So as TE increases, our signal decreases, and vice versa. And I talked about it at the beginning of today, where when we select a shorter TE, that's usually always associated with T1 weighted and proton density weighted images. You're going to get more signal because our signal hasn't decayed as much. And then your long TE pulse sequences, like a T2 weighted, you're going to have less signal when you're sampling it. So less signal with T2 weighted, but greater contrast to noise. That's why it's really good for pathology.
So less signal with T2 weighted and but better
contrast to noise. Yep. Because our fluid is bright. Using a really short TE prevents display of T2 contrast. That's why there's going to be more T1 or proton density weighted images. A long TE is going to give you that T2 rating. So we want to keep TE short to maximize our signal. So on these images here, corner of your screen, which one do you think has the longest TE? D. Good. So that is a TE of about 80 milliseconds. And then A, in comparison, is a TE of about 11 milliseconds. All right, flip angle. Flip angle is going to be a direct relationship. So as we increase our flip angle, we're going to increase our signal to noise ratio. So we have two flip angles on the screen here. So we have this oblique vector, and remember, a vector can be divided into, an oblique vector can be divided into two orthogonal vectors. And since we only have a 30-degree flip angle, our net magnetic vector that gets flipped into the transverse axis is going to be shorter than our 90-degree flip angle, which is going to flip the entire net magnetic vector. So your ideal flip angle for a spin echo pulse sequence is 90 degrees. That's going to give you the most signal. But we'll find out that with gradient echo pulse sequences, where our TRs are so short, we actually need a shorter flip angle to get more signal.
On this paper where it says blank up to Ernst angle, is it just supposed to be
Increases up to an Ernst angle. And that Ernst angle is dealing with gradient echo pulse sequence. But on the registry, they'll always ask, they ask about flip angle, they'll say it increases to a point, and that point is Ernst angle. So your ideal flip angle might be a 30-degree flip angle for a gradient echo pulse sequence, because we're trying to reduce the amount of saturation.
So the Ernst angle is not like a set number, it's not like...
It varies. It varies with the pulse sequence.
so that's the ideal angle for that?
Exactly. Yeah, that's a good way to put it. But in regards to this slide, we're really talking about a spin echo pulse sequence. So a flip angle of 90 degrees gives you maximum signal amplitude. Anything less or more is going to give you less signal amplitude. So small flip angles might need compensation, so you might have to increase your next. You might need larger voxels, which you're going to lose spatial resolution. And increasing your next also is associated with longer scan times. So we have two images here. both T1 weighted images, but the flip angle on the image on top is only 10 degrees. And then you have a 90-degree flip angle down below. And you can see how that entire net magnetic vector has gone into the transverse axis. Here, we only have a portion of that net magnetic vector that goes onto the transverse axis. So you can see how it's a very grainy image. And it looks like there's almost like an artifact streaking across the image also. So in summary, here it breaks down TR, TE, and flip angle. So TR and SNR are a direct relationship. So the longer the TR, the higher your signal. TE and SNR, it's an inverse relationship. So the longer the TE, more decaying happens, you're going to reduce your signal. And then we're back to a direct relationship with flip angle and signal. So a lower flip angle, like a 10-degree flip angle, will have less signal than like a 90-degree flip angle. But as we'll learn when we cover gradient echo pulse sequences, you actually have a desired flip angle for each TR. So it really is talking about a pulse sequence, but more specifically within that pulse sequence, a desired TR will give you a desired Ernst angle. So your signal increases up to what they say the Ernst angle. Just take that E out right here, Ernst angle. So we've covered the parameters that influence image contrast, but they also influence image quality, which were your TR, your TE, and flip angle. So remember, we talked about in Unit 2 how TR and TE give you desired image weightings, and that's also contrast, considered almost contrast. Now we're just going back on our extrinsic parameters that are really just dealing with signal. NSA, number of signal averages, or it could be NEX, number of excitations, or number of acquisitions. So that's more like your Philips scanners. NSA controls the amount of data stored in each line of K-space. So most of the time, we only need one next to fill the entire K-space. Remember, K-space is once we've filled K-space, we've basically finished that one slice. And once we've done all the slices, we've completed the pulse sequence. So each TR period, we fill one row K-space. And that's with an NSA of only 1. But if we increase NSA to 2, we go back and fill that same line of K-space again with signal. So you fill it with signal, but you also fill it with noise. And we know noise is random. We can't really compensate for the noise on your MR image. But increasing our next 2 actually starts to average out the signal. So we increase our signal, and we're starting to average out our noise. This is good sometimes for those patients that, they're not making drastic movements, but they're making slight movements in the scanner. Sometimes by increasing our next, we'll average out the noise or the motion of our image. But if we increase next too much, like if we put 5 next on there, our scan time is going to go way up. So it's not going to be that beneficial if they can't hold still for our 10-minute pulse sequence. So you have to find a nice balance. But if you just increase it to 2, your signal goes up and you might average out that motion artifact. But I just put on here, once again, that your NSA, they often compare it to going back and filling those drawers up with those socks again. Each line of K-space, each row of K-space gets filled twice for 2 next. Gets filled 3 times for 3 next. So we're increasing our signal and we're starting to average out our noise.
Direct relationship.
So I'll show you here in a second. It's not direct. This is one of the harder ones to grasp. So we're doubling the amount of data stored in each line of K-space when we double next. If we have next, we're having the amount of data stored in K-space. And then I mentioned here that data contains signal and noise. And our noise is going to be random, meaning it's going to be in a different position each time data is stored. Signal is not random. It's basically going to occurs at the same place, which is our readout gradient when it's collected. So here's 2 different images, axial brain with a field of view pretty small. So since our field of view is really small and we have high resolution, we need to bump up our next to get signal back. So here we have a very grainy image with a next of 1, and then we bump our next to 4, and now we have very high signal. So good question, Jeff. It's a direct relationship, but it's not proportional. This is the one that's really not going to be proportional. Remember, field of view, if we double it, we're increasing it by SNR by a factor of 4. So that's another one that's not really directly proportional. This NSA is also not directly proportional. So if we double NSA, we're going to increase SNR by 40%. And they get that number because whatever you increase your next to, you have to take the square root of that. So if you increase your next to 3, you take the square root of 3. So you can see here how as you increase your NSA, your increase of signal starts to plateau out. So it's not always the best way to increase signal. It's good for that initial bump, going from 1 next to 2 next, because we get 40% increase. But after that, our percentage of increase goes down steadily. So you can see here, we would never do 16 next, because that would take forever. And it really doesn't do that much for our signal from what we started with. Because you have to take the square root of 16 is only 4, right? So we've bumped up our signal by only 4 times. So it's not worth it. So you can see here how the biggest jump in signal is from 1 to 2, really. So 1 to 2, or maybe even going from 1 to 3. So be careful when you use your next, because it's really only increasing by the square root of whatever next you're using. And then here, this is when I mentioned how it starts to average out the noise, because noise is random. It's going to occur in a different place each time the data is sampled. So here we have a sagittal brain, and sometimes on those sagittal brains, you get a little bit of motion artifact on your mid-slice. By increasing our next to 4, our NSA to 4, that motion artifact has been averaged out. So sometimes it's beneficial that way. So trade-offs, we double SNR, we increase NSA by a factor of 4. Oh, I'm sorry. So to double SNR, you need to increase our NSA by a factor of 4, because remember, it's the square root of 4. So make that conversion, it's only by 2. But as we only double our signal, but our scan time quadruples. So that's not the best way to increase our signal. So you can see here how as we triple SNR, we have to increase NSA by a factor of 9 now. So the square root of 9 equals 3. So now our scan time, unfortunately, has been increased by 9 times. And as we start to get up these very high values, it's really going to increase the chance that the patient moves and can't get through that one pulse sequence. Because sometimes, you can warn the patient, this next pulse sequence is going to be pretty long, but I'll give you a break where you can maybe move around a little bit. But you don't want them to have a 10-minute pulse sequence and they go, I just can't. I can't do it. They start to move. All right, receiver bandwidth. This is where, I said that most of the time we're going to be compensating for signal because noise is random. But with receiver bandwidth, we can filter out that noise, which is on the edge of our signal amplitude. So our receiver bandwidth is the range of frequencies sampled during application of our readout gradient. So remember, if we have a receiver bandwidth of 32 kilohertz, remember our wave, the peak amplitude above center frequency is going to be like 16. You divide it into 2. And then below center frequency is going to be 16 also, just in the opposite polarity. But if we narrow our receiver bandwidth, what happens is we apply this filter. And what we can do with this filter is filter out the noise, which usually exists on the periphery of our wave, our signal wave. This image, I think, shows it a little bit better. So you always have noise kind of just gravitating towards the bottom of that signal amplitude and more on the periphery. Remember, we want to sample our signal at peak amplitude, at TE, right? And that's usually right in the middle because you rephase the signal and then it dephases again. So it's very symmetrical. So as it's rephasing, let's go ahead and just filter out the beginning of that rephasing of that signal. And then let's filter out the edge of the dephasing of that signal. So our signal never really changed because we keep the same good signal that we want, but we're just filtering out the noise. So as our receiver bandwidth decreases, so be careful on the registry or on my test and how it's worded. And if you see receiver bandwidth decreasing, that's associated with narrowing. So if receiver bandwidth decreases, our SNR increases. So this is going to be an inverse relationship. So if we have receiver bandwidth, if we make it more narrow, we're going to increase our SNR by 40%. Because once again, our noise is random. It could be very similar to the square root. And vice versa.
If you reduce it or narrow it, you said it increases SNR?
It increases SNR. But once again, we get trade-offs. So this image right here is a very narrow receiver bandwidth at 60. You have high signal, but the drawback here is we get a larger metal susceptibility artifact. Because you're actually getting more signal from that metal. That can be costly because it creates a larger void of signal that streaks across your image. So what happens on these metal protocols, what they call metal artifact reduction, MARS sequences? You have these in CT also. When they're trying to reduce the artifact from metal, is they widen the receiver bandwidth. They have a broad receiver bandwidth to reduce our metal susceptibility artifacts. It also does another thing. It reduces what we call chemical shift artifacts too. We'll cover that later on when we start to get to other artifacts. Broad, I would write this out, broad receiver bandwidth reduces metal artifact and chemical shift artifact. So if you guys are in clinic and, for some reason they're getting a big old signal void from the metal, their knee replacement, and the technologist asks, what would you do to try and reduce this metal artifact? The first answer would probably be to go to your receiver bandwidth and increase it or make it broader.
Broad RBW.
Broad receiver bandwidth reduces metal susceptibility artifact and chemical shift artifact.
And Mars.
Wait, what did you say? MR?
Metal.
Metal susceptibility.
Wasn't an acronym for that?
Mars.
Mars.
Oh, Mars, yeah, it's the sequence that you'll see on the scanner.
Oh, my Mars.
It's Mars stands for Metal Artifact Reduction Sequence. Metal Artifact Reduction Sequence. All right, so I included at the end of the chapter, they have a nice little chart here. This can help to start to fill out this. But you can see here, to maximize SNR, you adjust these parameters, and sometimes you have the consequences that come along with that. And then on your next slide here, you have all those extrinsic parameters. It shows you the benefits and limitations of those. So let's go over, without looking at this, where did we leave off?
ATM.
Yeah. Where? FOV? So we've already done increased slice thickness, right? Increased pixel size, signal's going to go up. Phase encoding steps increases if field of view stays the same. They have to word it like that. So if our phase encoding steps increase, what happens to our signal?
Increase.
Phase encoding steps increase. Does that give us more or less rows in K-space? More. Remember, the rows of K-space determine our pixel size. So if we have more rows, we have smaller pixels. So if we have smaller pixels, we have less signal. All right, the next one, direct relationship, increase TR, increase signal. One after that, TE, that's an inverse relationship. So as we increase TE, our signal's going to go down. We increase our flip angle, we increase signal up to the Ernst angle. Or if you say for a spin echo pulse sequence, the ideal flip angle would be 90 degrees. If we increase our NSA, it increases our signal, but it's not proportional. What's the amount it goes up by? 40% for the first one, but remember, it's square root of whatever we're increasing it by. So square root of, say, 2. Square root of 9 is only 3. So. Okay. So let's leave it off from there, and we'll go on to the next PowerPoint. All right. So once again, we're constantly balancing these things for image quality. Signal to noise, contrast to noise, spatial resolution, and CNR. All right. Another influence of signal can be our coil type. So I think I briefly mentioned this before. If we have just a linear coil, you're really only going to get one RF pulse. You're not going to get that much signal. But if we have a quadrature coil, we have two coils that are going to be 90 degrees from each other, create 2 RF pulses, and it increases our signal by 40%. Our phase array coil, where do we use a phase array coil? What anatomy? It's fine, good, because we can turn on different sections of that phased array coil. And we have smaller coils that are going to be lying down the entire spine. Because remember, smaller coils usually give us more signal than the larger coils. You get more coverage with the larger coils, but you get better signal from the smaller coils. Say if you have a coil that's 8 centimeters in diameter, how deep does that usually penetrate? 4 to 5, because it's like 50% to 70% of that coil diameter. So good. And then if we are using a surface coil, we want to place that surface coil as close to the region of interest as possible. So here we have a knee sequence where we're using 2 different coils. And if you have more channels, that's going to increase your signal. So if you hear the word channel, we're increasing the amount of coils. So here we have on the left a 2-channel knee coil. Gives us decent signal, but our 16-channel knee coil is really going to optimize our signal. So then we are also able to change our matrix size, and then our scan time went down too. So if you have an option, a lot of places have 2 separate knee coils, and people sometimes will like to use a lower channel coil just because they work with it more often and they're more comfortable with it. But if you do have a larger or a higher channel knee coil, go ahead and use it because you're going to get better signal and you might be able to reduce your scan time as well and increase your resolution. So always questioning kind of what the techs are doing. When you get to your site, kind of ask you here are all your coils, but maybe what channel kind of coils do you have? Are they transmit and receive, or are they just receive? Things like that, so you get an idea of all your different coils that work. Because you'll see certain techs kind of go for the ones that they always have worked with and they're familiar with. All right, so when we're selecting a coil, we have certain criteria to think about. So we need to select the smallest coil to demonstrate a certain region of interest. So if we're covering the abdomen, obviously it's a very, very large area of coverage. So we need, for our Siemens coils, we usually have to put one up top and one down below. Almost like our 14 by 17 cassettes for X-ray. You usually have to get the diaphragm, and then you have to get the pubic symphysis, right? Crosswise. But with our GE scanners, they have a very large body coil, and it covers from the diaphragm down to the pubic symphysis. But if you're doing the elbow, you're going to use either a knee coil or a flex coil that you can wrap around the elbow. So just make sure you're choosing the smallest coil for that body part. Make sure that the region of inches is in sensitive range of the coil. So a lot of times people will use these great coils and then accidentally not select that coil. And only the body coil was turned on, and they're not going to get the best signal for that. And usually it only takes one pulse sequence to realize that. And they go, oh, I forgot to turn the coil on. And then they got to run it again. Positioning of that coil is very important to maximize the signal. So be sure that the surface coil is perpendicular. So if it is an abdomen, make sure it's laying on the flat. If it's a shoulder, make sure it's flat, not at an angle. Or if it is, against the side of the shoulder, make sure it's perpendicular. So you always want orthogonal planes with these coils. Angling a coil will result in reduction of signal. So here's an image of how they position the coil. And for a shoulder, which is already, you're not dealing with much signal to begin with, because it's a pretty thick body part, and either we're using a flex coil or we have that already designed, prefabricated coil that the patient has to slide into. So make sure that the coil is laid on the patient in perpendicular fashion. So it could either be laid almost in the coronal fashion here, or like the sagittal fashion. But make sure it's not angled in any way. We talked about this a little bit, where spin echo pulse sequence are going to generate more signal than gradient echo pulse sequences. Because of that 180-degree refocusing. And typically, we're going to use our spin echo pulse sequences anytime we have metal within the body. So for those Mars sequences, metal artifact reduction sequences, those are going to be spin echo compared to gradient echo. Because that gradient echo lacks that 180-degree refocusing pulse, which doesn't compensate for that metal susceptibility artifact as well. So if you're trying to get more signal or reduce metal artifact, always choose spin echo versus gradient echo. Here's just two images, and it shows you how that artifact looks compared to the spin echo. Fat saturation also increases that metal artifact too, so this image is also fat satted. That could be another reason why this metal artifact is showing up larger. So a lot of times you'll see on your Emory protocols, if you have metal within the body, they say run the post-contrast sequences, but don't turn on your fat sat, because that artifact gets larger with the fat sat. So in summary, these are all the factors that influence SNR. We've talked about magnetic field strength, photon density, voxel volume, TRTE, flip angle, number of signal averages, receiver bandwidth, coil type, and pulse sequence selection. Any questions on those? You guys feel pretty confident in those? All right, now let's switch gears and talk about contrast to noise ratio. Contrast to noise ratio, once again, is the ability to differentiate between areas of high and low signal. So it's the SNR between two adjacent structures. So if you have an area, what?
You meant to put S instead of C.
No, this is C.
Oh, okay.
Contrast to noise.
It was on the other.
I hope I meant to do that.
Oh, yeah, I got it.
So high areas of signal are going to appear bright, and low areas of signal are going to appear dark. So we have very high contrast to noise between these two structures, where the head of the humerus has been nulled because there's fat within the bone marrow, and we've used fat saturation to make it dark, and then we have to contrast from our arthrogram study within that joint space. Everybody's done an arthrogram and X-ray, right? You haven't done an arthrogram? You know what two body parts are most commonly arthrogram?
Yep.
Hip and shoulder. Most of the time for an MRI, you guys are going to be mostly doing shoulder, but we also do hips too. But you'll occasionally get like a knee or a wrist, things like that. So the factors that influence contrast to noise are going to be the exact same parameters that affect SNR. So nothing changes here. So, but contrast to noise is the most critical factor affecting the image quality. And the reason is because it's really just how our radiologist's eye is able to distinguish areas of high signals from areas of low signals. Image contrast depends on both intrinsic and extrinsic parameters. So when we do, say, that arthrogram, when we have fluid, contrast fluid within the joint space, and then everything else is nulled out because of that saturation, sometimes we're able to discern those lesions or that pathology from normal tissue. So that's why we're doing it. That's why we inject contrast, because it was hard to see on the T1 pre-contrast, and now, it now appears bright. I know there's some kind of pathology on the T1 post-contrast. So the purpose of administrating contrast material, which is gadolinium, is to magnify the difference between normal and pathological tissue. So these are things that increase our contrast to noise ratio. Your image weighting. Which one has a higher contrast to noise? We've talked about this. T1 or T2? Contrast to noise?
T2.
T2, because remember, fluid is bright. So next step, put T2, higher contrast noise. Our contrast agents. So I'll show you some images pre-contrast, and I'll show you some images post-contrast, how your eye gets drawn to that contrast material. Chemical pre-saturation. Our post-contrast images are usually fat-satted, so all our adipose tissue and the bone marrow, fatty bone marrow, get nulled out also. And then we also have what we call magnetization transfer contrast. And we'll talk about these later on in subsequent chapters, but I just wanted to kind of briefly mention them here. And then flow-related techniques. So our time of flight and our phase contrast flow techniques, they're great at detecting blood flow. So you'll see the arteries and the veins within the blood, and then it saturates all the stationary tissue. So flowing blood is going to appear bright, but all the tissue that just sits there and remains stationary becomes saturated and dark. So that's why on your time of flight, all you see is the vessels, your circle of Willis. And magnetization transfer contrast, that's where you're kind of using a counter gradient to null the signal in the background. So a lot of times MTC is used on your time of flight to suppress the background tissue even more. All right. So just looking at these two images, see how the pathology, remember pathology is usually pretty water-based, is going to appear bright. Compared to our pathology here, it is dark. Contrast. T1 pre-contrast versus a post-contrast. Our eye is getting drawn to that bright area signal. Here's that contrast. These contrasts can be either IV, oral, or sometimes they even inject a contrast like into the rectum for rectal cancer. Here's our pre-saturation pulses, our fat-sat pulses. So here, in this pathology almost looks like muscle, right? But then we fat-sat everything, and that pathology really pops out. Hard to see on the sagittal too, but it's there. We have a couple different things. We have a T1 right here, non-fat-sat. We have an axial T2, fat-satted. Then we have an axial T1, and then this is post-contrast. So you can see how your contrast noise increases as we start to suppress adipose tissue. Magnetization transfer, like I said, it's good at additionally suppressing background tissue so that we're able to see those small vessels even better. We're able to delineate the circle of Willis even better. So they improve our time of flight imaging. All right, and our last little bit we need to cover is spatial resolution. Spatial resolutions, by definition, is the ability to distinguish between 2 points as separate and distinct. And our spatial resolution is controlled by our voxel size. And your voxel size can change by changing your slice thickness, your field of view, or your matrix. So those are the only 3 things that can change your voxel size. So those are the 3 things that are going to affect your spatial resolution. So we've kind of talked about this already, but small voxels, we have high spatial resolution, large voxels, low spatial resolution. So sometimes you guys started, as you were listening to me when we were talking about signal, you were picking up what it does to your spatial resolution as well. So I don't think we need to go through this as in depth as we've done before. But you guys were able to make that connection where if you increase your signal, most of the time your spatial resolution is going to decrease. This is just a reminder, an isotropic voxel is this where the dimensions are equal and the resolution is the same in every plane. Slice thickness. Thinner slices, greater spatial resolution. Matrix size. So if we have a larger matrix or a fine matrix, we're going to have better spatial resolution. Larger or fine matrix, better spatial resolution. So over here you can see this would be considered a fine matrix on the right. On the left here is a coarse matrix. Field of view. The size of our field of view also determines our pixel dimensions. So if we have a very large field of view and our matrix stayed the same, so you always have to, when you're talking about field of view in conjunction with your matrix, you have to say one increases and what happens to the other. So a large field of view, if you increase your field of view but your matrix stays the same, we're going to get larger pixels. Okay? And just the opposite. If your field of view shrinks down, but you have the same matrix, you're going to get smaller pixels. So once again, we control the geometry of the voxels. So we control field of view, slice thickness, and imaging matrix. If your phase and frequency are the same dimensions, you're going to get what we call a square voxel. If they're uneven, you're going to get what's called a rectangular or anisotropic voxel. So you can see here as you get a rectangular pixel, it decreases our spatial resolution. Ideally, we want a square pixel. However, sometimes we use this when we're imaging very long and narrow body parts to reduce the amount of phase encoding steps that we need. So with a rectangular field of view, we're really just having the amount of phase encoding steps. So we're getting a rectangular field of view, but we're also getting a rectangular pixel. So our spatial resolution goes down a little bit, but what happens that's beneficial is our scan time goes down. Because remember, our number of phase encoding steps is part of the scan time equation. So here, all we did was decrease the phase field of view, and we have almost the same image quality, but we were able to reduce our scan time by 2. So what other body parts, like what other anatomy would we use a rectangular field of view? Humors, femur, very long and narrow structures. So this is what's happening. You're just filling less rows of K-space. So your matrix dimensions in the field, in the phase direction are going to decrease. But once again, we're not really concerned with these pixels out here, because that's just posterior subcutaneous fat, and then you got abdominal tissue, which we're not really concerned with on an L spine. So the main thing we do for rectangular field of view is to reduce scan time. Okay, so in summary, to improve image quality, spatial resolution must be optimized. Spatial resolution can be maintained by selecting a thin slice, selecting a fine matrix, and selecting a small field of view, and whenever possible, selecting a rectangular field of view when imaging like the humerus, the femur, or the lumbar spine. Just remember, scan time, as we increase all these amazing parameters, Sometimes, we're going to have to bump up that scan time from 2 minutes to 4 minutes. You have to think about the type of patient you have. If you have a claustrophobic patient, if you have a patient that's in a lot of pain, sometimes, not having as much signal or resolution is okay, as long as you're getting a halfway decent image. But just remember to put that in your tech notes. Let the radiologist know, like, this patient, it's very hard for them to hold still. Best images possible, things like that. And if you ever have to repeat a sequence, sometimes send that through just so that the radiologist knows that you tried it at least twice, You didn't just get a crappy image and go, oh, I'm going to move on, you know what I mean? So don't worry about how it looks. Just send that also and just say, see, patient was unable to hold still for this sequence. So here are the factors that affect scan time, which we already talked about. So TR and scan time have a direct relationship. Phase matrix and scan time have a direct relationship. And then next and scan time have a direct relationship. Remember, it's not like with signal where you increase your next and it's going to be the square root of whatever you increase it by. But with scan time, it's going to be a direct relationship. That's proportional. To this point, we've only learned one scan time equation, but there are actually 3 you need to know for the registry. And they're not that much different. The main thing that's always incorporated in all 3 is TR, phase encodings, and next. But if we are doing a turbo spin echo or a fast spin echo, we basically have to take whatever we got and divide it by our echo train length. And then if we're doing a volume imaging or a 3D acquisition, we just multiply it by the number of slices, not the slice thickness. That's the one way they'll trick you on the registry. They'll give you all these parameters, and then they'll give you a slice thickness and the number of slices, and a lot of people use slice thickness in the equation instead of number of slices. All right, so don't forget your trade-off. So let me go back to that before I lose my voice completely here. Just trying to get through it. Let me find that Excel sheet, and we'll just finish up what we had started. All right. So we were on ETL. So this is the one Nick asked about. So the number of ETL increases, actually your SNR decreases, and I remember why. So that because it actually increases your amount of noise. So it speeds up your scan time, but you actually get blurring a lot of the times because you're more concerned with filling the center of K-space. And then sometimes you don't get much signal from those echoes that fill the outer lines of K-space, and that creates blurring on your MR image. So your noise is actually increasing. All right, number of increased phase oversampling. We're going to increase the number of phase encoding steps. So that's, so we don't want the nose to wrap into the back of the head. That's what I'm talking about here with this oversampling. So we're going to increase our signal, but it's also going to increase our scan time. Partial Fourier. We kind of talked about this when we were talking about K-space, but that's where we fill K-space partially. And since K-space is symmetrical, right? Remember the top half is equivalent to the bottom half? We just fill the rest with zeros. So what happens there is our signal goes down because only partial data is collected. But sometimes we're not as concerned with our signal as concerned with time. Parallel imaging, we'll cover this a little bit later, but our signal goes down. So as our acceleration factor increases, our SNR goes down. But our scan time decreases, which is great. We really use parallel imaging when we have a patient that can't hold still or can't hold their breath. Reduce our narrow receiver bandwidth. That increases our signal because remember, we're filtering out the noise that's in the periphery of the signal. We're filtering that signal out, that noise out. Higher channel coils, like quadrature, phase array, and surface, increases our signal. But remember, you have to lay those coils on the patient in a perpendicular fashion. As we increase the number of slices, we're covering a lot more area, so we have more hydrogen protons within that area, so it increases our signal. This is really kind of dealing with 3D acquisitions, and sometimes if you won't see slice, you'll see what we call slab. So anytime you see on your MR console where you're thinking you're increasing your slices, but then it's substituted by a word that it says slab, and that's dealing with 3D. You use volume imaging compared to slices, it increases our signal because you're exciting a whole area of tissue compared to just one slice. So that's why our 3D acquisitions always have more signal than our 2D acquisitions. If you have any type of slice gap or interleave, how much slice gap should we have, percentage-wise?
10 to 30.
10 to 30, good. So that's good because it reduces what we have, that crosstalk artifact, or cross-excitation, which is noise. Anytime you have an artifact, that's noise. So that increases our SNR because we're reducing the N in that SNR. These last two we talked about extensively. Spin echo is always going to have more signal than gradient echo due to that 180-degree refocusing pulse. T2 versus T1 and PD is going to have less signal because that signal has decayed a lot longer. Our TEs on a T2 pulse sequence are typically longer than your T1 and your proton density. And then you have your resolution parameters down here. So as you increase your field of view, but then you can also say as your matrix stays the same. So always put that as matrix stays the same. Your resolution is going to go down. As your slice thickness goes up, your resolution goes down. Number of pixels increases. You could say within a field of view. That remains constant. Your resolution is going to go up. Fine matrix, resolution goes up. Rectangular field of view, it says it stays the same. It's going to be a little off because they are anisotropic voxels, meaning they are not, that every dimension is not equivalent. But your scan time decreases, and that's the big thing here. And if you use a steep gradient slope, remember that kind of goes with that initial question that Nick asked at the beginning of the lecture. If you use a steep gradient slope, you're filling the outer lines. So we will review this the next time we meet. So once again, we have 4th of July. You guys get this Wednesday off. We'll have class next Monday to review this material. We'll have our lab on Wednesday. And then you gotta just watch the echo lectures. You can rewatch these videos, whatever you gotta do to study for this test. Feel free to use it. Any questions? You guys okay?